Welcome to our Explainer. Have you ever come across a bacterium that's such a good actor it can mimic appendicitis and send a patient straight to the OR? Well, today we are doing a deep dive into exactly that bug, the fascinating and clinically deceptive pathogen Yersinia enterocolitica.
Just before we jump in, a quick note. All the information we're covering today was compiled using Gemini Deep Search with some great images from Microbe Canvas. And if you want to check out the primary sources, the full notebook document is linked right below for you.
All right, so here's the game plan. We'll start with a profile of the organism itself. Then we'll look at the different ways Yersiniosis presents. After that, we'll head into the lab for identification, talk treatment, and finally, wrap up with prevention and control.
First things first, let's get properly introduced to this organism. So what are we dealing with here? It's a facultatively anaerobic, gram-negative coccobacillus. But the real key takeaway is this. It's a major zoonotic enteropathogen, and for the strains that make humans sick, pigs are the #1 reservoir. And it's got a pretty clear history in the books. While the genus was named way back in 1894, this particular bug was first described in 1939, and then, in 1964, it got the official name we use today, Yersinia enterocolitica.
Okay, now this is one of the coolest things about this bacterium. It's got this brilliant strategic switch. See, out in the environment, at room temp, it's fully motile, swimming around with its flagella. But the second it gets inside a warm-blooded host, at 37 degrees Celsius, it drops the flagella. It goes completely non-motile. Why? It's conserving energy to switch gears and crank up the production of its virulence factors. It's an incredibly smart survival tactic.
So, let's move out of the lab and into the clinic. What does this infection actually look like in people?
And this is where it gets really wild, clinically speaking. The patient's age completely changes the picture. In little kids, under 5, it usually presents as a pretty standard case of enterocolitis. But in older children and adults, it causes this intense inflammation in the terminal ileum that perfectly mimics appendicitis. We're talking right lower quadrant pain, fever, the works. It's no wonder it gets called pseudoappendicitis. So how does it pull all this off? Well, it has a whole toolkit of virulence factors. The star of the show is the PYV virulence plasmid. It basically builds a molecular syringe, a type 3 secretion system, that injects these effector proteins called YAPs directly into our immune cells, completely disarming them from the inside. It's an amazing piece of microbial machinery.
Now here's a real puzzle for microbiologists. There's this group, biotype 1a, that's long been considered non-pathogenic because it doesn't have that classic PYV plasmid, but we're finding it more and more in patients who have diarrhea. This is really challenging the old way of thinking and suggests these strains have a whole different and still mysterious way of causing disease.
So with all that complexity, how do we actually nail down the identification on the bench? Let's walk through the lab workflow.
Under the microscope, you're looking for those small, gram-negative coccobacilli. And if you get a good look, you might spot that classic bipolar staining. It's not always there, but when it is, it gives the cells that really distinct safety pin appearance.
For culture, there are 2 really critical things to remember. First, you need the right selective media, which is CIN agar. Second, and this is key, you have to incubate it at a lower temperature, around 25 to 30 degrees Celsius. Yersinia enterocolitica is a psychrotroph. It loves the cold. So this gives it a huge growth advantage over all the other gut bacteria.
And if you do everything right, this is your reward. That iconic bullseye colony on the CN plate. The deep red center comes from mannitol fermentation, and it's just one of the most distinctive and honestly beautiful colony morphologies out there.
This table is basically your biochemical checklist to confirm the ID. A few big ones to point out, it's oxidase negative, but rapidly urease positive and ODC positive. And of course, there's that temperature-dependent motility again. It's motile at 25 degrees, but non-motile at 37. That's a huge clue. Of course, these days we have molecular diagnostics, which are fantastic. Targeting the PL gene gives you a super fast and sensitive answer right from the stool sample. But there's a catch. A PCR result is just data. It's not an organism. You don't get an isolate for susceptibility testing. That's why having a reflex culture policy is so important. Any positive molecular result should automatically trigger a culture, so you get that vital isolate for AST and surveillance. And that whole challenge, getting an isolate to guide therapy, leads us perfectly into our next section, how we connect what we find in the lab directly to patient treatment.
Okay, this is a non-negotiable, must-know fact for any microbiologist. Yersinia enterocolitica is intrinsically resistant to ampicillin, amoxicillin, and first-gen cephalosporins. It has the beta-lactamase genes to prove it, so if you ever have an isolate that's testing susceptible to ampicillin, that should be a massive red flag to go back and double-check your ID.
When we look at treating serious infections in adults, there's a bit of variation in the guidelines. For instance, the Dutch SWAB guidelines lean towards ciprofloxacin as the first choice. Other international guidelines often start with trimethoprim sulfamethoxazole. But for systemic infections, pretty much everyone agrees that third-generation cephalosporins are the way to go.
For kids with severe disease, the drug choices are similar, but the dosing, of course, is critical. The mainstays of therapy are trimethoprim sulfamethoxazole and IV third-gen cephalosporins, like ceftriaxone or cefotaxime, all with their dosages carefully calculated based on the child's weight.
And for those of you in the lab running the susceptibility tests, we follow the EUCAS breakpoints for Enterobacterialis. This table gives us the clear MIC cutoffs that let us interpret whether an isolate is susceptible or resistant to those key antibiotics we've been talking about.
All right, last section. We've identified it and we've treated it. Now, how do we stop people from getting infected in the first place?
You know, for all the complex microbiology we've discussed, the most important prevention tip is incredibly simple. Cook pork all the way through, especially ground pork. You want to hit a minimum internal temperature of 71 degrees Celsius, that's 160 Fahrenheit. A food thermometer is really your best defense here.
So, this brings us back to that big question for the future of our field. As molecular diagnostics get faster and more common, how are we going to balance that incredible speed with the very real, very urgent need for physical isolates to track antimicrobial resistance? It's a huge challenge. We'd love to hear what you think about it in the comments. And hey, if you found this explainer helpful, please hit that subscribe button for more. Thanks for watching.